proceed.
Hereby, I open this academic ceremony in which Mohit Manoj Nair will defend the academic thesis Reframing and Unpacking Irrational Antibiotic Use, a Structural and Socio-Ecological Perspective on Antibiotic Resistance in India. May I invite you to present a summary of your study and the conclusions of your thesis.
Thank you very much, dear Prorector. I will share my screen now. Prorector, dear highly esteemed members of the Corona, dear family and friends present in the audience today. Thank you so much for joining me in the presentation of my dissertation entitled Reframing and Unpacking Irrational Antibiotic Use, a Structural and Socio-Ecological Perspective on Antibiotic Resistance in India. I wanted to start by quickly highlighting some of the key accomplishments as part of this dissertation. The dissertation is organized in 5 chapters, systematically moving from a survey and qualitative study, assessing the knowledge, attitudes, and practices in chapters 1 and 2 respectively, to a systematic review of behavioral interventions to address antibiotic use in outpatient settings in chapter 3, a qualitative study examining gaps in policy-based and structural interventions in primary healthcare in chapter 4, and finally, a critical policy analysis of the Indian National Action Plan to tackle antimicrobial resistance in chapter 5. Now, 4 of the 5 chapters are already published in a wide variety of international academic journals, including PLOS ONE, Tropical Medicine and International Health, as well as the Journal of Global Antimicrobial Resistance, while 1 chapter is currently under peer review. So why study this? What is the significance? The advent of antibiotics ushered in a new era of quick cures and reduced morbidity and mortality. But as an Indian citizen myself and a public health researcher, I see a troubling pattern where we now have a double disease burden. Neglected and communicable diseases that are easily preventable continue to exact a heavy toll, while non-communicable diseases such as cancer and cardiovascular disease cause further morbidity and mortality. At the same time, the WHO warns that antibiotic resistance is accelerating and rising to unprecedented levels around the world due to overuse in humans, animals, and the environment, creating conditions where minor injuries that were once treatable might once again be deadly. And in fact, antibiotic resistance is predicted to be the world's largest killer by 2050, surpassing even cancer. And low and middle income countries like India see rampant prescriptions of antibiotics, hence the focus on India in this case. The first 2 chapters of my dissertation focus on a mixed method study that examined the knowledge, attitudes, and practices of formal and informal healthcare providers, as well as community members who accessed care in a district of West Bengal. While the quantitative and qualitative studies are voluminous and presented as 2 distinct chapters, I wanted to just highlight that the study as a whole adopted a sequential explanatory approach to understand both the prevalence of irrational antibiotic use, as well as the knowledge, attitudes, and practices using a scored survey that then triangulated this data with an in-depth understanding of the drivers via qualitative methods. A self-administered 38-question CAP survey tool was provided to various practitioners in order to gauge knowledge, attitudes, and practices. We defined appropriate antibiotic use as the right antibiotic at the right time, in the right dose, and at the right duration. And since a complete list of providers was not available in the district, we utilized a convenient sample of 384 providers that were evenly stratified between 4 groups: 96 informal providers, 96 allopathic doctors, nurses, and pharmacy providers. I also wanted to share, we used the term pharmacy providers because it was impossible to determine with the various people we were interviewing at chemist shops whether they were licensed pharmacists in a setting like this, where one pharmacy license is often shared across various shops, and that's important context for the work. In addition to a survey, we also conducted 28 in-depth interviews with each of the provider groups as well as community members. And community members were purposefully sampled based on geographic proximity to the district hospital and more remote areas closer to the primary health centers or subcenters. So what did we find? A quick note on demographics. Overall, the vast majority of participants, about 70%, were male, and the proportions of informal health providers and pharmacy shopkeepers in particular were heavily skewed towards men, whereas nurses were entirely female, which reflects the overall population of healthcare providers across most states in India. Furthermore, just over half of the participants had over 10 years of work experience, which was particularly notable among informal health providers who relied heavily on experience for decision-making in their professional work. On this slide, we're just looking at one of the knowledge questions in the survey. We can see that the knowledge of allopathic doctors contrasted strongly with the other three groups, as you would expect, and this result was statistically significant. About 76% of allopathic doctors either strongly disagreed or disagreed with the statement that antibiotics were useful for viral infections, the correct answer, and significantly smaller proportions of non-allopathic doctors or informal providers, nurses and pharmacy providers answered this question correctly. Interestingly, high proportions of informal health providers, pharmacy shopkeepers, and nurses claimed that knowledge of antibiotics was important to them in their role as a health provider, even though by law, none of these groups are legally permitted to prescribe antibiotics. And there was no statistically significant difference between attitudes as a whole, which were quite similar between all four groups. The most pronounced finding, however, was the dissonance between knowledge and practices, wherein participants could correctly identify appropriate uses of antibiotics and yet simultaneously fail to apply them in practice. A higher proportion of nurses, pharmacy providers, and non-allopathic providers avoided antibiotics for patients who presented with a cold or sore throat in comparison to allopathic doctors who had comparatively better knowledge. The qualitative portion of this sequential explanatory study, detailed in Chapter 2, shed additional insight into these prescription practices and decision-making. I've highlighted a few abridged findings here. Firstly, while some allopathic doctors clearly stated that they refused to prescribe antibiotics without clinical indication, others reiterated that antibiotics are, quote, necessary in order to get cured. Doctors frequently mentioned that they prescribed antibiotics as a precautionary measure, which was linked to other factors such as an unhygienic working condition in the patient's home or in the facility, poor sanitation as a whole, lack of follow-up, as well as diagnostic uncertainty. Another salient theme which emerged from our interviews was the strong desire to acquire new knowledge among formal and informal health providers alike. Pharmaceutical company representatives, or PCRs, were seen as a key source of new knowledge, and many informal health providers said they attended meetings and seminars that were organized by these PCRs, as you can see by the quote on the screen. Quote, big pharmaceutical companies invite me and the speaker is a big doctor. If there is a new medicine, we get to know from PCRs. If PCRs don't come, then how will we know? Moving upstream to think about the doctor-patient relationship as a whole, this relationship was found to be quite frayed in several instances. Patients viewed doctors as out to make money, as demonstrated in the quote on the right, and switched providers frequently if the treatment was perceived as being too slow or ineffective. Meanwhile, on the other hand, doctors routinely reported that they were worried about being blamed for faulty treatment by patients. Multiple doctors expressed fear for their lives, given the threats to personal well-being from angry patients. Having established an understanding of the motivations behind some of the prescription decisions and the confluence of social determinants of healthcare with patient demands in chapters 1 and 2, chapter 3 moved on to looking at the current evidence landscape regarding interventions to influence antibiotic prescribing behavior in outpatient settings, which is an underrepresented area in the literature as a whole, especially for low and middle income countries. In total, 3,514 abstracts were screened by 2 authors, including myself. 42 studies were selected for full text review, and 13 studies were included in the final narrative synthesis. We defined behavioral interventions as persuasive, enabling, restrictive, structural, or bundle, which is a mix of different interventions. And as a whole, our review found that enabling or educational interventions alone may not be sufficient to overcome the ingrained incentives associated with inappropriate prescriptions. Bundle interventions are comparatively much more effective. And our study supports others, such as those conducted by Pearson, Chandler, and others, who found that high levels of awareness across 9 different low-income settings did not translate into a reduction in misuse of antibiotics. A quick note on limitations. Given the heterogeneity of some of the studies, we were unable to conduct a meta-analysis, and we opted for a narrative synthesis instead. And our review focused solely on prescription behavior and did not take into account behavioral interventions that targeted consumers or the general public. Also, most of the studies included in the review measured changes over a fairly short period of time and did not account for long-term or sustainable changes in that behavior. And despite the fact that the generalizability may be limited in scope, I think there are very important lessons to be gleaned from the varied interventions and the countries represented across Southeast and South Asia in this review. Chapter 4, which is currently under peer review, moved beyond the literature to conduct 23 semi-structured in-depth interviews with key informants and experts across a broad range of disciplines in academia, nonprofits, pharmacy, medicine, policymaking, among others. Data were charted into a framework matrix and analyzed using a hybrid inductive and deductive thematic analysis. Themes were analyzed and organized according to the various levels of the socio-ecological model, which ranges from the individual level all the way up to the policy or enabling environment. And again, here, individual or organization level interventions included things like hospital-specific antibiotic stewardship efforts, as well as trainings for individual prescribers. There was a recognition that educational interventions that targeted the individual or interpersonal interactions were largely ineffective, similar to the findings from the systematic review in Chapter 3. Instead, policy-level interventions needed to incorporate behavioral nudge interventions, improve the healthcare infrastructure, and embrace task shifting to rectify some of the systematic disparities, such as staffing issues in rural areas. Key informants also expressed the need to adopt a hub-and-spoke model to target informal providers via existing networks, leverage the role of pharmaceutical companies in decoupling sales and incentives. There's a conversation to be had there about the feasibility of this in an overall economy that's structured the way it is, and critically examine the enforcement of existing policies such as Schedule H1. Chapter 5 takes a deep dive into the National Action Plan to tackle antimicrobial resistance in India and examines the shortcomings in the current policy from a design and implementation perspective, while presenting concrete recommendations moving forward. An important limitation here is that, as recognized by the highly esteemed committee members, this chapter does not utilize a structured policy analysis framework, such as Walt's policy triangle. However, the various elements of an analytical framework like this are included and could be easily applied to understand some of the same shortcomings. As an example, in terms of the context for policymaking, commitment for antimicrobial resistance has been building in India since 2011, when the health ministers of the Southeast Asia region's member states articulated their commitment to tackle this issue through the Jaipur Declaration and prioritize it in national policymaking. However, the approach to policymaking has largely been top-down and modeled after the Global Action Plan, without engaging many of the things that make the Indian healthcare system so unique, the multi-sectoral and diverse cadre of healthcare professionals in India. And while the National Action Plan does successfully integrate feedback from government ministries, clinicians, and microbiologists, as well as international experts and policymakers, Ayush practitioners, that's the Ayurveda, Unani, Siddha, homeopathy, or our traditional systems of medicine in India, and informal providers are left out, which is a glaring gap. And the sort of perspectives of the primary healthcare workforce representatives are often missed at the grassroots level. Taken together, the 5 chapters present a comprehensive picture of the drivers of antibiotic use in India and similarly structured low and middle income countries, and advocate for a nuanced policy-oriented perspective that moves beyond limiting our conception to irrational antibiotic use to critiquing the very concept of rational behavior in a context where structural limitations to access are the norm. The problem is not as simple as a deficit in knowledge, and the knowledge practice gap can only be addressed by embracing the One Health paradigm, utilizing multifaceted bundle interventions that move beyond education, leveraging, recognizing, and appreciating the diversity and potential of India's multifaceted and pluralistic healthcare system to critically address infrastructural gaps in access before we look at excess, and be grounded in policy and systems change that recognizes the role of social determinants in governing individual and institutional behavior. Thank you very much for your time. I would especially like to thank my supervisor, Professor Dr. Maurice Ziegers, and my co-supervisor, Dr. Saqib Burza, without whom this research and PhD journey would not have been possible. Thank you also to the countless participants who contributed to the work, especially patients and community members in West Bengal, Médecins Sans Frontières staff, and other field staff. And thank you very much to the highly esteemed committee members in the audience. I look forward to your questions, and I will now yield the floor back to the prorector.
Thank you very much for your presentation. We will now start with the opposition, and the opposition will be opened by Professor van Schaik, Professor of Preventive Medicine in General Practice at Maastricht University. Professor van Schaik, the floor is yours.
Thank you so much, Prorector. Dear candidate, it was really a pleasure to read your thesis. It's a very important topic, not only in India, but I think all over the world. And it's a topic as well in the Netherlands. So it was really a pleasure to read such a topical thesis. I have several questions, and I will restrict it mainly to chapter 1. In chapter 1, you make some very interesting observations. So I will start with your abstract. And in the abstract, you're saying that many doctors knew that antibiotics were not indicated for viral infections, but over 87% reported prescribing them in this situation, which is rather alarming. The other thing is what you're saying is that more than 30%, 30.8% of the providers relied on pharma information, so pharmaceutical company representatives, as your major source of information about antibiotics, which is rather worrying as well. Taken together, those two percentages, so the what you're saying, 87%, and you're saying more than 30%, which means that there is still many, let's say, possibilities which are explaining the 87%, which cannot be explained by the 38% or 30.8%. Can you say a little bit more about it? What do you think, what are the most important factors which are influencing the prescription behavior of doctors?
Thank you so much, highly esteemed committee member, for that question. I really appreciate that question in particular because I think it highlights in a nutshell some of the glaring gaps we saw. I just want to take a moment to recognize a few things that you raised accurately. You know, one of the things is that we see this knowledge practice gap, especially among allopathic doctors. So a lot of people assume that knowledge is the problem. Medical doctors, as we saw, had really commendable knowledge, as we would expect. And yet, when applied to practice, and this is consistent across the literature with other folks who have studied this issue, they often show higher gaps in knowledge and practice compared to other provider groups, right? And from the observations that we made at outpatient departments where there would be pharma representatives waiting to speak to them, you know, it's important to recognize these are just the front-facing sort of perspective of the pharma industry. There are many ways in which the pharma industry interacts with medical doctors and others. One of the unique findings about this study was that the pharma industry has also actually managed to make significant inroads in the informal sector. But with regards to the formal sector and the allopathic doctors that you mentioned, some of the other things that could explain some of the drivers, you know, that's where our qualitative study came in really handy, because a simple survey that just asks about knowledge, attitudes, and practices does not unpack that. And when we got to do the rich in-depth interviews, we saw things like fear of sort of repercussions by patients or by families, right? So this blame shifting where patients would blame doctors and doctors would blame patients, and no one was to blame for the issue of antibiotic resistance. That was one factor that sort of contributed to prescription decisions. Even beyond that, things like wanting to sort of retain patients if you are a private sector provider, that influenced the decision to prescribe antibiotics. There were glaring infrastructural gaps. Things like, you know, you don't have the luxury of bringing a patient back for follow-up. You don't have diagnostic tests in the outpatient setting. If you look at an outpatient department in India, as you very well know, you know, you would have 300 people in the course of a couple hours to just run through. Each patient is getting a minute. So I think all of these things weigh into those prescription decisions.
Would you say then that patients are more or less in the driver's seat?
I think that's interesting. Many of the doctors wouldn't admit to that. And I don't know, we can't really assess the extent to which the patient piece weighed in heavily over the other factors. I would argue some of the infrastructural limitations are probably more important to some of the prescription decisions you're seeing. And there also we can dichotomize between sort of short-term things and long-term recommendations.
To go a little bit further about education, I think one of the intriguing factors that you found in this chapter is that there was a dissonance between knowledge and practice. That is, let's say, the key issue that you found. Participants could correctly identify appropriate use of antibiotics and yet fail to apply these findings. When there is a dissonance between knowledge and practice, education can never be a solution. So we should not focus on education. That is more or less a key finding. You are telling in later chapters a little bit more about the multifaceted intervention beyond knowledge. How would that work in practice? How would it go? Just given, let's say, a practical example.
Thank you very much for the question. It's been studied in some settings, and there are states like Kerala that have implemented things like this. But it basically, I would say that the focus is not to solely focus on education, but tie that to some of the other interventions.
Yeah.
Some of the things that have been attempted in the literature on this have been things like audit and feedback and peer comparison interventions. But even beyond that, that is an example of a bundle intervention. I think what we found is that the structural interventions that get at the infrastructure issues are far more important, even than some of the other interventions that combine knowledge with academic detailing or audit and feedback. These interventions like peer comparison, audit, and feedback in high income settings have been attempted across the board, shown a lot of success. I think it'll take a while because in the context like India, the glaring issue is one of healthcare infrastructure.
I understand, yeah. Do I have still time left for one remaining question? Yeah. Then I would like to go to page 22 in your thesis. That's figure 2. You also presented it during your presentation. And that's quite interesting. That is, let's say, the agreement with the statement that antibiotics are useful for viral infection. And you see a huge difference between allopathic doctors and the remaining informal healthcare providers. So nurses and pharmacy shopkeepers. What I always understood from India, that it's the same situation as in the UK and in the Netherlands, that informal practitioners, healthcare providers, are not entitled to prescribe antibiotics. Is that correct? That's in India the case as well?
That's correct. By law, yes.
Yeah, by law. But are you more or less suggesting by this figure that the real practice is opposite?
Absolutely. I would say, I mean, I witnessed it firsthand watching antibiotics get dispersed. And I think a lot of people who have studied this will see that firsthand as well. It is happening across many different rural areas.
If so, how would you enforce that it's against the law, what's happening? So
I'm so glad you asked that question.
Yeah, how can you enforce this?
Yeah, I think a lot of the focus has gone on enforcement, right? There is a Schedule H1 for over-the-counter use. There is a focus on, if you ask the Indian Medical Association, their response is always crack down against the quacks, the informal health providers. They're the fault. That's why antibiotic resistance is happening. The problem is, again, we're seeing a fundamental access issue. The reason informal health providers exist is because our current healthcare system cannot meet the needs of the rural healthcare system. I think other, highly esteemed committee members here have studied this issue and talked about things like in the context of independent India, how we had a pluralistic healthcare system which recognized informal health providers. That was quickly abolished. The state stepped in and made them quote unquote illegal. And I think what that did is that it pushed them into the dark corners, the recesses, the nooks and crannies of states like West Bengal, where they're important and they're setting up private networks with doctors to meet the needs of healthcare. But at the same time, that means that there is a recognition by policy stakeholders that you can't crack down on them. You need to have them there in order to meet the basic needs of healthcare. That's why you're seeing enforcement issues.
Now, thank you so much. It remains an intriguing issue. So thank you so much, and we'll give the word back to the product.
Thank you very much. The opposition will now be continued by Professor de Jong. He's Professor of Healthcare System and Governance at Maastricht University and part of NIVEL, the Netherlands Institute for Health Services Research. Professor de Jong.
Thank you, Madam Pro-Rector. Dear candidates, I also read your thesis with great interest. You provide several insights that are new and very relevant for addressing problems related to antibiotic use. You addressed antibiotic use as behavior that is influenced by structural factors and socio-ecological environment, and thus pointing at where changes should be made in order to change antibiotic use. In your thesis, you propose several solutions. In practice, changing antibiotic use will be quite complex as it involves changes at the macro, the meso, and the micro level. And I wondered, what would you recommend policymakers to start with?
Thank you very much for the question, highly esteemed committee member. I think I really appreciate that framework of micro, meso, and macro. I think, again, one of the things our review focused on was that some of the macro level interventions are where the need is highest. But the biggest thing overall is to focus on access before excess, right? So I think the reason that you're seeing a lot of the irrational antibiotic use, as people put it, is because there isn't a social safety net for people to fall back on. People are in search of quick cures. There isn't a sort of time for convalescence, as the literature has shown as well, in a place like India. If you were to able to build in some of these things to focus on building out a primary healthcare system that meets the needs of our patients, if you were to able to formalize some of the informal providers a little bit more to go back to the setting we had where the needs of the rural health sector were met adequately, then I think you could focus more on some of the individual or micro level knowledge related interventions that you want to focus on, right, as a society. Right now, focusing on just those micro level interventions, and by that I mean things that are knowledge enhancement focused, things that are focusing overly on guidelines, those kind of things are effective, but they're effective in a very limited context. And I don't think it's going to address the glaring gap you see across rural India in terms of access.
Yeah, and do you believe that when changes on access are made, that patients are expecting different things? Because I think you kind of get trapped. Patients are expecting antibiotics, providers are prescribing antibiotics because otherwise they will lose patients. But will that change when you make structural changes?
I think it's a good question and it needs to be studied, but I think that you can get to a point where at least the decisions behind prescriptions are not solely driven by lack of diagnostics, lack of testing issues. So you take away some of those factors and what remains then is this interplay between doctor and patients. I'm glad you raised that because I think one of the findings incidentally in our research has been this faulty relationship or this fraying relationship between doctors and patients. And I think that's also a fundamental issue, right? I think it gets to, if you look at any media reports across India, a lot of people talk about doctors being beaten up, about sort of patients being left to the wayside, not being treated. And I think this sort of dichotomy of like the patient's right and the doctor's right and this tension that's being created, it reduces trust in the healthcare system as a whole. And I think we underestimate the value of that trust as it relates to things that are seemingly concrete, like antibiotic use. So I think once we address that, we can get at some of these other issues that are more downstream.
Yeah, but I think one thing we know and that it's very difficult to build trust.
Yeah.
How do you think about it? How would you increase trust between patients and providers?
I think, actually, I'm reminded of quotes that I saw that I witnessed in the actual outpatient setting. And a lot of people say, look at the patients I'm seeing. I get maybe max 1 minute, 2 minutes per patient. I have to I have a standard set of prescription. I'll give a antibiotic. I'll give something like metronidazole for diarrheal infections, and I have to just move on to the next patient. In that setting where you have 1 to 2 minutes per patient, there is no way to establish trust. That same provider then said, if I saw this patient in my private clinic, I will give him 20 to 30 minutes and actually talk through things. Why is that luxury afforded in the private sector? Why do we have that, right? For those patients who are privileged enough, such as myself, to access the private sector for care, and to be mindful, there are many issues with the private sector as well. I think there are certain luxuries afforded, including building a trusted doctor-patient relationship in primary healthcare that you just don't get currently in our government system.
Mm-hmm. Yeah, I understand. Is it feasible?
I think it is feasible. I think one of the practical problems is that the funding allocated for this is measly. I think even now in the National Health Plan, if you look at India, there's a huge focus on tertiary care and hospitalizations and very little on primary healthcare. There's a focus on creating health and wellness centers, which sounds good on paper. But again, if you look at the practical reality, even if those were fully functional, as one of the highly esteemed committee members has done her own research on, they would not meet the needs of rural healthcare. So it requires a political commitment and follow through that seems impractical, but you need to take the first step of, I think, allocating the appropriate financial resources for it.
Yeah. And how long do you think it will take to change?
That is a very tough question, I think, outside the scope of my research here. But I do think we're still decades away from it. I think it's going to take a long time to see that reality.
Yeah, well, actually, you pointed it in your thesis, of course, that it will take a long time, and you had some ideas on what to do in the meantime, like scaling up access to point-of-care tests. But also with that, I wondered, why do you think that will work?
That's a great question. I think in the work that I did, I tried to differentiate between short-term interventions and long-term. It's very easy to argue that this is a socio-ecological issue. We need to focus on infrastructure. We all know it'll take a long time. In the meantime, there are patients who need access to care right away. I think there are a couple of things. Point of care tests and access to rapid diagnostic tests, it will help us differentiate, what some of those issues around lab testing and understanding right away. Is it a clinical, is it a viral infection? Is it a bacterial infection? That'll get at some of the knowledge gaps that are there for prescribers who are in the formal setting, at least. At the same time, you can focus on things like aligning the Schedule H1, which is the regulation that's there for over-the-counter use, with some of the WHO's AWARE criteria, ensuring that access antibiotics are available across the counter, and then looping in informal providers and pharmaceutical company representatives into this sort of nexus of care that meets the needs of rural India, because there are already these networks that exist. There are providers in the formal sector who rely on informal health providers as a source of revenue and to meet the basic needs. If we could tap into that network, there are WhatsApp groups, that I was privy to when I was doing this research. If you could tap into those networks, I think there's ways to look at this network of care.
Yeah, and when you do those tests, then you know whether antibiotics are the right remedy. But still, I wondered, something puzzled me, that patients are shopping around. So when they don't like what they get from their provider, they're going somewhere else. So would they accept it?
That's a good question. I think the feasibility remains to be seen. It's very likely we'll still see patients shopping around. I want to point out one of the reasons patients move around is because they have realized that in the private sector, doctors, quote, make a customer out of us. In the public sector, I'm not getting the quality time that I see. And again, the last piece, they don't have time for convalescence. Like when we get ill, we can take sick leave, we can recover. There's not that luxury in the rural sector right now in India, even in many urban settings. And I think addressing and creating some of those social safety nets for people to have that luxury will help some of these things downstream.
Yeah, okay. Well, thank you very much.
Thank you very much.
The opposition will now be continued by Dr. Kamenchikova, Assistant Professor at the Department of Health Ethics and Society at Maastricht University. Dr. Kamenchikova.
Thank you, Madam Prorector. Dear candidate, congratulations to you and to your supervisor for finalizing this PhD thesis, which addresses a very important public health problem, has already been highlighted by other committee members. And I read your thesis with great interest. And I would like to continue discussion that already started by other candidates with regards to formality and informality in antibiotic use practices. So as you showed in your thesis, these practices do not just exist parallel to each other, but they're actually entangled and they depend on each other. So we see this kind of lines of codependence and co-construction between formality and informality of antibiotic use. And as you showed in your work, and as we also know from scholars working in a similar field, informal infrastructures are often emerging as a response to infrastructural gaps, inequalities, and injustices from formal systems. And one of the suggestions that you made in your thesis, page 27, and that we've heard you highlighted now during your defense, is that future efforts must work to strengthen the existing public health infrastructures. And I would like to maybe focus a little bit on this statement. As we know, concept of infrastructure had acquired quite a big space in the literature on antibiotic use. And I would like to ask you to maybe unpack it a little bit. In your specific work, what do you mean when you refer to public health infrastructures? Maybe I will start with this and then I will ask a follow-up question.
Thank you very much, esteemed committee member, for this question. I also read your thesis with a lot of interest because I believe the parallels to Russian healthcare, I think there's a lot of interesting parallels in my work as well. You speak about a boundary object and what that means for people who have a standardized set of languages. When you're talking about infrastructure, I think your work ties into Claire Chandler's work and Alex Broom's work on this as well. And I've seen very similar things. I think there are two pieces to this about sort of understanding how informalities are created, and that it's the state that creates informality in many ways. And these parallel markets exist because there is a glaring gap in access that's currently present. One of the reasons we ask about, why is it that we can't enforce existing laws? The laws are on paper. The reason is there are actually there are policy professionals who have said it's easier to ignore existing regulations than enforce them. If they enforce them, there would be a hue and outcry. There would be glaring gaps in our healthcare metrics, which would get way worse. So when we say, what do we mean by infrastructure? I use a very similar definition to scholars across the field, whether it be, Dr. Broom or Dr. Chandler, but I think about it in the Indian context of primary healthcare in particular. I think about those government healthcare settings that are serving our most vulnerable individuals. And I think about how even if those were fully functional right now, and if the financial allocations were fully in play, they would not meet the needs of our patient population. And so I think about infrastructure, both in terms of the primary healthcare in the formal setting, insurance coverage to ensure private sector care, because to date, more than 70% access care in the private sector in India. And that's forecasted to continue. We can argue that we rely heavily on the public sector and sort of enforce policies accordingly, but I don't think the private sector is actually going to go away as a result. So I think we need to kind of work together on that and enforce coverage across the board. With regards to the informal sector and infrastructure, I would say there are needs to tap into these networks that already exist between the pharmacy representatives, the informal sector, and the formal providers. Right now, in my research, we saw that many times, an informal provider will contact a formal provider for advice about certain courses of action. And they'll say, you can do this, you can prescribe this and this, you can give the patient to stabilize them. If they're not responding, you need to refer them to me, or you need to bring them. And then the unsaid portion of this is that the patient will then go and access, as a sort of referral, this private doctor that the informal provider is connected to. So in exchange for knowledge, I think there's a financial compensation by way of a patient referral that's happening. If these networks already exist, I think there's ways to sort of understand this and go back to a setting like 1947, 1950, where we had a diverse cadre that was recognized. I think infrastructure, even if we fully implement our funding allocation and we, have all doctors and nurses at government healthcare facilities, it is still insufficient to meet the needs of our population today. So I think it's very difficult to do this without recognizing the informal as part of our infrastructure.
Yeah, thank you for that. I think indeed it's interesting that informal already exists as a part of formal. But then I'm curious, what would be your suggestions to move forward? Because what you've shown in your work is that because still legally it is an informal system, while they can benefit from certain links such as acquisition of knowledge or acquisition of certain resources from formal systems, they are still positioned in the sphere of illegality. So they still cannot fully benefit from formality of public health systems. So I was wondering what would be your suggestion of how to manage these two parallel infrastructures. One is formal and legal, and another is informal and illegal.
That's a great question. I think the practical difficulties are definitely at play. And I think, you have to recognize that there are laws on the books that are not being enforced. They're not going to be enforced anytime soon with the way that things are headed, despite heavy lobbying by the Indian Medical Association and others who are looking at this issue as purely an issue in the informal sector. I think there's ways to involve them, right? For example, the government of India created a bridge course for quote unquote Ayush practitioners. This is our traditional medical providers. It's important to differentiate them from informal providers because there is formality associated with traditional providers. So they're dealing with Ayurveda and these other systems of Indian medicine. That's accorded some formality under this current government. And they have actually been enveloped to give them some rights to be able to see patients. I think if there were pilots like that done where you were having short-term courses or informal sort of arrangements being made, then I think there are ways to sort of set a cornerstone or a pilot to demonstrate success. And there's states that are moving towards that, whether it be Chhattisgarh or West Bengal. There have been bridge courses that have been introduced. I think something like that at a small scale can demonstrate success and then make a case for why these informal providers need to be grouped in from a legal standpoint, which will still take a decade or more.
But I'm wondering, what do you think are current hindrances towards such integration? Because as your work, but also as work of other scholars show that indeed such integration would be beneficial. So in a sense, we already have evidence, but apparently this evidence is not enough to change systems at the moment. So what would you indicate as the main hindrances at the moment while we already have evidence?
I think there's an inertia to action in policymaking in India, right? So I think there are so many things to be covering in the media. And I think this gets at the issue of how do you take a policy and make it mainstream enough to interact with a broad array of stakeholders, right? It doesn't just get made in sort of top-down structures. Right now, policymaking in India is quite top-down. I think there's a lot of pressure exerted by formal groups like the Indian Medical Association. I think if we were to have more people who are conducting some of these studies, also liaising with patient groups, then I think there could be some change that's made. There is evidence of this. You know, when I was working with Médecins Sans Frontières in Bihar, we did this for palliative care and for HIV/AIDS. You know, we showed how evidence of access is sort of impeded, and we sort of used that operationally to advocate for palliative care for this unique group of people. That eventually led to the opening of a new facility and sort of more interactions with some of these senior policy level folks. So I think if we could tie this research and ensure that it doesn't just get disseminated in journals by senior academics, but also is liaised with patient advocacy groups, which do exist. There are so many, you know, PL-HIV advocacy groups for HIV, for example, where there's no other recourse other than for them to advocate for themselves. I think there are these patient groups that exist, and you could build relationships to disseminate this research and exert pressure on policymakers. I think that would make a difference in the long term.
Thank you. Madam Prorector, do I have more time to ask a question?
No, I think your time is up. Sorry.
Thank you.
We continue to the next opponent, which is Dr. Gautam, Assistant Professor of Health System and Health Policy at the London School of Hygiene and Tropical Medicine. Dr. Gautam.
Thank you, Madam Prorector. And my congratulations to the candidate for picking up such an important topic for your research. And I would say that it's not just a problem in India, it's also a problem in many countries in the world, where increasingly healthcare for the poor is being delivered from drug shops, which are the equivalent of the informal sector in India. And I think it deserves a lot more attention than it is receiving right now. So the world really needs researchers like you who are able to unpack not just what is happening at the surface level in terms of the practices, but who is also able to unpack the politics behind it and understand and highlight the structural deficiencies. So I really want to congratulate you once again on taking up this topic and coming up with a very, very logical and a very in-depth thesis. I've also been enjoying the way that you've tackled the questions from everyone. I'm very impressed by the way that you have understood the politics behind it, the way that you are presenting the conflicts of interest which go on between the formal and the informal. So I'm just going to continue from the policy implications that Dr. Kamanchikova began talking to you about, because in my view, that is something that really needs to be understood and addressed a lot better by researchers like us going forward. And so coming to your chapter 5, where you have very correctly, you have highlighted the dissonance between the National Action Plan and all of your findings, especially about the informal sector. So my first question is that, as you have explained, that the informal sector is not something new. It's not something that's just come up. It's a result of a state process of formalization of the medical profession that has created this kind of an informality, which has not gone away because we have not been able to meet the needs of the poor through the formal health system. and they continue to be unmet. So as long as that happens, the informal sector will always be there. So given the fact that it's been around since independence, why do you think that kind of a shocking and huge reality is not being reflected in our national action plans or in global action plans? So that's my first question. And my second one would be, what would be your top 2 or 3 recommendations to make the national action plan more responsive and a more practical strategic action plan?
Thank you so much, esteemed committee member. And I just want to take a moment to recognize that I draw a lot of inspiration from your work as well. I think there's very few scholars working on India, right? And it's a handful of folks, and a lot of them are in the room right now. And I just want to say, I think one of the reasons that glaring gaps exist is because we have an issue of competing priorities. We have, since independence, there's so many issues that have come to play. One glaring gap in my own work right now is that I realized we conducted this in the middle of COVID. If you look at what happened in India during COVID, AMR just suddenly took a complete backseat, right? Like we didn't even talk about it because we were just talking about meeting the glaring shortfall and the crisis that was present. India is a situation where we face multiple crises. There isn't a luxury of sort of moving forward and planning for things. And I think in that kind of context, we're always 2 steps behind. So that's the first issue with what we see. And I think a little bit of proactive planning with appropriate funding allocations, coordination between the center and the states in terms sort of how funding is allocated, a recognition of states that have taken the bold step of engaging with Ayush practitioners, with informal providers, and scaling that, really like doing large scale models. I think that could really help. And then to your second question about concrete policy recommendations from the plan, the first thing is strengthening the healthcare infrastructure, as we talked about, but also looking at this WHO aware categorization and looking at how our current schedule, Schedule H1, doesn't align with that, which is something you highlight a lot in your work, right? So we have access antibiotics like amoxicillin and ampicillin that are being used that don't, they're not adequately characterized in our Schedule H1. You have watch and reserve antibiotics. Right now, we have a situation where policymakers are reluctant to enforce any regulation. So they're very strict on paper, but there's no enforcement. I think if we could focus on smart regulation, focus on things that actually, have a chance at being implemented and align them more with what we know to be the ground reality, we'll see a better inclination to enforce things with the reserve antibiotics and with the watch antibiotics where the problems lie. I think you have to do that in order to sort of meet some of the access needs first. Secondly, again, utilizing the diverse cadre of healthcare providers, recognizing pluralistic healthcare. You have a workforce in India. It's already come about because of these decades of inaction, right? And even if you sort of strengthened Indian medical schools even more, ensured that people mandatory, had to be in rural settings for 1 to 2 years at a time in their early career, you would not meet the needs. And when you see those doctor-patient interactions, they will always be rushed. And there won't be sort of a desire to engage properly. You have this rural cadre of practitioners who are already there. If you look at how the global action plan and the national action plan has been formulated, they have been ignored completely in this formulation. To the credit of the government of India, they've modeled it after the WHO, they've followed the playbook exactly, and they have successfully looped in different government ministries to focus on One Health, right? And that's great. But I think they've missed out the Ayush practitioners and the informal providers. They have not focused on the financial allocations. It's easy to say, let's increase financial allocations, but we know it doesn't get done. So what are some of the more practical considerations around smart regulation that we could focus on, looking at how Schedule H1 could be implemented, and then looking at how the linkages between various healthcare programs that are organized vertically, for example, HIV, TB, and how they talk to each other when it comes to an issue like AMR, which is horizontal. It cuts across all programs.
Yeah, thanks. That's absolutely spot on. So what would be, I couldn't agree less with all of that. We need to do all that. But we also realize that it's not going to be an easy path forward. So can you tell me a little bit about what kind of barriers, what kind of challenges do you see, knowing that there's a lot of politics involved? So, yeah.
Thank you for that. I think that's very true. I think if we talk about the informal being formalized, as other committee members were referring to, it'll take some time. I think the patient pressure is not there, and the coordination between actors who do policy advocacy is not there for this issue at the moment. But at the same time, there's World Antibiotic Awareness Week, and there are different places that are raising awareness around this. I think to make a movement, you could again classify what's possible in the short term and what takes a longer term to sort of coordinate. So in the action plan, you have things that focus on surveillance in tertiary care settings, right? You could build hub and spoke models and make sure that at the minimum, community acquired settings and community settings are represented in that, and that you have that sort of decentralized nature represented. I think the other barriers are clear in terms of competing priorities. This is not sort of a top issue when you have other things that are more immediate and more front and center. This is an issue that takes a backseat. Even if you look at who dies from antibiotic resistance, it's very difficult to classify a death as being due to a resistant infection, right? There's many downstream things that sort of are the immediate cause of death. So I think it's not a very big politically like front and center issue. And I think there's going to need to be an addressing of those challenges before you move forward.
Right. Thank you very much. And I think that's all that I have to ask, Madam Pro-Rector. Thank you very much, the candidate, and all the best.
Thank you.
Thank you. Then we go to the last opponent of this session. That is Dr. Kenny. Dr. Kenny is a research fellow, sociology and social policy of the University of Sydney. Welcome, and the floor is yours.
Thank you, Madam Pro-Rector. Dear candidate, congratulations on completing a really rich, detailed, and carefully argued thesis. I want to echo the sentiments of the other committee members. This is a real accomplishment that details sort of, that displays a really fine-grained analysis of such an important issue. I was particularly impressed by the fact that four of the chapters are already published articles and that the fifth is under review. So the first question I wanted to ask builds on, I guess, chapter 4 of the thesis, but also on proposition 5 that you laid out in your list of propositions. So I was wondering if I could first ask you to read that proposition number 5.
Sure, I have it here. Thank you so much. Proposition number 5 is focusing on individual behavior change is unlikely to contribute to any sustained change in practice, as long as patients are able to move from one provider to the next in a private market in search of quick cures, and hospital policies prioritize short-term patient outcomes over the long-term impacts of antibiotic resistance.
Great. So there are a couple of issues throughout that proposition that I'd love to hear a little bit more about. The first, sort of putting it into dialogue with chapter 4, one of the sort of main takeaways I took away from chapter 4 was that in the sort of socio-ecological model, you sort of discuss from the level of the individual up to the level of the sort of the health governance of hospitals. And I was wondering if I could get you to sort of push that a little bit further, moving from the micro through the meso up to the really high level macro. Because in that chapter 4, you sort of argued that a lot of your respondents in the qualitative interviews pointed to those structural barriers to change here. And so I'm wondering if you can talk a little bit more about those really high level macro structural barriers. And I'm thinking here particularly about really the question of the sort of global economic system of capitalism. So to sort of make that slightly more manageable, I was wondering if you might say a little bit more about how the problem of AMR fits into the current global landscape of global health that, you know, a number of scholars have described as being characterized by various forms of philanthrocapitalism. And I wonder, especially when you talk about sort of rapid diagnostics and point of care testing, whether this plays into a sort of Gatesian model that often comes at the expense of real investment and development of the infrastructure of healthcare. And I guess the other side of that is that, you know, a lot of this discussion is geared around misuse and sort of retaining the viability of our existing antimicrobial resources. I wonder how the other side of the equation, which is the drug development pipeline, is inadequately incentivized by the sort of capitalist market model.
Thank you so much, esteemed committee member, for that question. I really appreciate this. I think it's a lens that it's an important one to take to frame the thesis as a whole, because I think a lot of the issues, again, we're talking about stopgap measures. It's easy to say, you know, that pharmaceutical companies should delink sales volumes from from the way that they're from volume, right? Total volume. But like, why would they do that? Why it doesn't make any sense in our current capitalistic system, where really it's about a fee-for-service system in the private sector. And it's about a model where you really benefit from exclusive patent periods. You benefit from basically gatekeeping access. And so I really appreciate the recognition that there is a limitation to all of this in our current system. And I think India, has parallel systems in place. So I think it's interesting, there was a desire to move towards a single payer model and have a government-oriented system, and then a burgeoning private sector came into the play. That's very difficult to regulate. And I think it's something we need to understand. But I would say that there are many different issues at play in a capitalistic economy. There are things that are within the ambit of our control, and there are things that are far outside and would require an overhaul of the way the economy is structured as a whole. So I think some of the things, in a context where rent-seeking, profit-seeking is the norm by pharmaceutical companies, it's very difficult to regulate that. And I think it's actually irrational to expect a government to step in and be like, you're not going to be able to do this. I'm surprised by actually some of the enforcement around patent law and how we've pushed back against major US-based pharmaceutical companies who want to extend patent periods, and how our generic manufacturers have been able to improve access. I think that is huge. I think there are unique models like the Drugs for Neglected Diseases Initiative, which is a collaboration by several partners I've worked with in the past. And I think they show a unique business model where they recognize that for diseases like Chagas disease, visceral leishmaniasis, there is an insufficient market out there. There's never going to be a market that will sort of incentivize treatment for these diseases. And so you need unique models where you really have public sector players taking the charge and coordinating between various private sector players to sort of build these treatments and disseminate them, and sort of ensure that there's equity across the board for these. And I think that speaks to some of the problems with that Gatesian approach of sort of looking at just rapid diagnostics and point of care testing. The reason to include those, I would say, is just because you do need some stopgap measures, I think, because there is a recognition that there is a gap between knowledge and practice. And if you can get at some of those issues around basic infrastructure of labs and testing delays, I think if you can get that in the outpatient setting, you take that barrier out. And then, you're left with these major systemic issues of how you deal with pharmaceutical companies and deregulation. The last piece I'll say about this is that there is a role to be played among, in terms of social pressure. I would say I am impressed by, whether it be for climate change or even the context we see around Russia and Ukraine right now, the pressure that can be exerted for companies to pull out and to create change that way. And I think social pressure from consumers does play into that a little bit. I think it doesn't get at some of the structural factors in a capitalistic economy, but it does force actors to comply within a limited sort of setting.
Great. I'll push you a little bit further then and ask how the sort of wins around patent exclusivity, for example, have the somewhat sort of perverse consequence of disincentivizing further drug development. So I would love to hear your thoughts on that sort of tangle of consequences.
Thank you for that question. I think as part of Chapter 4, in one of the interviews, I was privileged to be able to speak with really senior partners at various institutions involved in drug development, as well as policy stakeholders. I was dismayed by the main policy recommendations always being incentivizing the big pharmaceutical industry to fix some of these issues around subsidies and the patent pipeline, right? So the interventions focused on extending patent protection, like evergreening and other practices, making sure that there are sort of guaranteed subscription payments if you want to move away from a fee-for-service model. I think that's one approach, and I think it's one that gets a lot of attention. I think there are other models, as I mentioned, the Drugs for Neglected Diseases Initiative, where there are other models like that are possible to meet this glaring gap. And I would say that we need to pair both and think critically every time we sort of allocate more money towards sort of the big pharmaceutical industry to sort of fix some of these underlying glaring gaps.
Madam Rector, do I have time for one more question? Excellent. So I guess this is a question about temporality and political salience, because as we all know, AMR is a slow burn problem. A lot of these require immediate solutions while not losing sight of those longer range goals. At the same time, it's very hard to bring something front and center politically if it's not a crisis like COVID, like you've described. So I guess I'd be interested in your thoughts on what it would take to sort of increase the political salience of the problem of AMR, both in policy spheres, but also within sort of broader public.
I would say in terms of the broader public, first of all, thank you for that question. In terms of the broader public, there's already things that are being done, such as the Red Line campaign, where people have, there's medication that's like marked out and said, this is not for use. It's a red line, do not cross. There's things like that. There's World Antibiotic Awareness Week that people are tapping into. I think it is a slow burning process. It'll be really difficult. I think where patient advocacy groups have been really helpful is sort of understanding the long-term consequences of losing a loved one to something like this. And I think that's where liaising between advocacy groups that already exist for other conditions and tying the issue of AMR to those conditions could be really helpful. In the context of COVID, you look at a sample prescription and doctors were throwing the kitchen sink at patients, right? I think there were prescriptions down the road, and you can't blame them for that because I think nothing was working. We didn't have a treatment at play. So I think
Mr. Nair, the Beadle just announced that it's harassed. So the time for, you're very enthusiastic, but the time for defending your thesis has passed, and the degree committee will now withdraw to discuss the quality of your thesis and your defense. I request that you and your company await the results of our deliberations and our return. Mr. Mohit Manoj Nair, the degree committee here present online has assessed the quality of your thesis and your defense. In view of its positive verdict and taking into account your previous qualifications, the degree committee has decided to grant you the degree of doctor. Professor Zegers is authorized to confer upon you this academic distinction in accordance with Dutch university custom. I invite your supervisor to now take the floor.
Do you promise to work in accordance with the principles of scientific integrity at all times, to be careful and honest, transparent, independent, and responsible? Now you have to say, yes, I promise.
Yes, I promise.
By the authority vested in us by law and in conformity with the decision of the committee here present online, I hereby confer upon you, Mohit Manoj Nair, the degree of doctor, and grant you all rights attached by custom and law. As evidence of this, you will soon receive the degree certificate signed by the rector, the secretary, and the supervisor, affixed with the official seal of the university now shown by the beadle. The laudatio will now be continued by Dr. Boerse.
Thank you to the esteemed committee, and thank you to Dr. Nair for a wonderful presentation. So I'm not going to take a long time for this level of praise, because I think a lot of Mohit's work has spoken for itself, both in the richness of the publication and the thesis, as well as a very strong defense that was made today that I think we were all universally impressed with. I have known Mohit for about 6 years now, and Mohit has shown himself to be an experienced social research scientist, and he's shown himself to have a real, genuine interest and a passion for public health evaluation over the last 6 years, where I've seen him grow from an already intelligent, passionate, curious scientist into someone who today has achieved his PhD. He's always had a focus and an interest in historically marginalized populations, refugees, people living with HIV, children and young adults with disabilities. His academic career started in Cornell University, where he did a Bachelor's of Science in Biological Science, where he also then proceeded to do an MPH following that at Harvard, the School of Public Health, where he concentrated on humanitarian studies, ethics, and human rights. Following that, he's taken on a wide range of roles, which is atypically for a scientist, including direct care international interactions in care settings. Part of this was his experience in the care of children with disabilities quite early into his career, which has really framed his academic and career pathway with a focus on vulnerable populations and stigma associated with these populations. As a researcher at Harvard, he conducted a wide review of peace building and conflict resolution efforts in Uganda and Burundi, and also researched conflict drivers for youth in Palestine as part of a wider and broader UNICEF study. He's also assisted in the evaluation of disasters and emergency preparedness programs, focusing on trying to build capacities amongst those humanitarian actors who were on a global foothold. Throughout this, he's maintained a very strong link with India. He's designed and conducted mixed method studies outside of what we've seen today. And Mohit has quite a number of publications that really sit outside the AMR sphere, which have demonstrated his interest and his passion for vulnerable populations, and scratching the surface of these really some untouched subjects within the Indian settings that can be quite difficult and sensitive to address. I personally first met Mohit in 2017 when I was the lead for medical activities with Doctors Without Borders across Asia. And I was, as MSF, I'm sure many of you know the organization. It's a humanitarian organization. And we typically work in, let's say, quantitative figures. We implement projects which focus on morbidity or mortality, which are defined by numbers. And we typically follow old models of care, which are established over years, which perhaps aren't questioned anywhere near as much as they should be in terms of effectiveness. We think we know the what, but we don't really know the how. And this is the bit that I really wanted to look at in some of our activities in India, specifically when we had projects focusing on AMR in West Bengal and also on HIV, visceral leishmaniasis in Bihar. Mohit came to us as quite a surprising profile, eager, fluent in Japanese, something that you just don't tend to see every day. And someone who could have taken many roles, both in India and at the international settings in the US and so on, but chose to commit himself to a horrifically underpaid, difficult position with MSF. Over the subsequent 3 to 4 years, I worked with Mohit closely in a lot of the research paradigms that we explored. AMR, some of them he mentioned already, AMR, palliative care in HIV patients, perceptions of patients with co-infection and how stigmatized they are within the system at hand. He wrote a very strong paper that really dug into this level of stigma that we see in the Indian setting, and similar topics and similar themes that came across with the AMR topic as well. Thinking about the fact that AMR is controlled legally in the way that HIV stigma is prohibited legally by penalty of law, yet it is absolutely endemic in these areas. And being able to have that approach with doctors that allowed them to open up, to admit that they were committing crimes by stigmatizing, demonstrates the level of confidence that they had in Mohit's both academic and ethical approach to the research that he was doing. The output of his work with us has been that we have changed policy within MSF. We have addressed entirely new questions that we really didn't know about before. And as Mohit said himself, we actually opened an entire project based in no small amount to his research. And we're talking about tens of millions of euros spent in treating advanced HIV patients in Bihar who otherwise would have had no access to care, partly as a result of the work that Mohit has done. So with this said, I'd like to say thank you to Mohit. Thank you for the learning experience that you've given both myself and Maurice. You've been a hands-off, hands-free, independent researcher who's only asked us for help when you've known when to ask for help, but you've been so proficient at the work that you've done, and you've done your background reading, you've done the hard work, the digging into the literature that's framed your knowledge to make sure that you knew what you didn't know, so to speak. That it's been a real pleasure supervising you, and I can only say that I wish you the best future. You have a stellar career ahead of you. Please do continue to keep an eye on the pathway that you have about vulnerable populations, vulnerable topics, and maintain that friendliness and that very genuine approach that allows you to cut through difficult topics with people. And I'll close it with that. And I'd just like to say also on behalf of the committee that everyone's very happy, and we'd like to thank the committee as well for taking the time to read your thesis, for taking the time to clearly really think about the sorts of questions that you've brought up, and to give, I think, a good challenge and a robust opposition throughout the process. I hope you've enjoyed it. It's been enjoyable for all of us. And congratulations again, Dr. Nair.
Thank you very much. Dear Dr. Nair, also on behalf of the Board of Deans of Maastricht University, I'd like to congratulate you with the honor you have acquired. It's a pity you can't be present in Maastricht, but it's nice to be able to have the ceremony anyway. And you did very well. It's clear you're very passionate about the topic, and even in the middle of the night, because for you it's in the middle of the night, this ceremony, it's amazing that you're able to bring that passion over to the committee members as well. Thank you for that. I'd also like, of course, to congratulate your family, friends, and colleagues with this special day. I'd like to congratulate the supervising team with a great PhD defense. I would like to thank all the Corona members for their work in assessing the thesis, and also for being present here. They're from over the world, very different time zones, so a lot of people had to adapt. For us, it's the middle of the day, so that's not so such a problem. But it was great that you could all attend, and I thank you very much. And with that, and wishing you a very good continuation of the night or the day. I don't know whether you're going to celebrate, or that will have to wait till tomorrow. But anyway, with this, I'd like to close this academic session.